بسم الله الرحمن الرحيم. طبعا احنا في اخر يوم بقى هحاول ان انا ما اطولش عليكم، لان المره ليها اسبكتس كتيره، لكن ان شاء الله ما اطولش عليكم ان شاء الله. طبعا يسعدني ان انا المره يمكن كل المرات موجود فيها في مؤتمر طب اسكندريه. طب اسكندريه طبعا دي يعني عزيزه عليا، لان هي بلد والدتي وبلد حبايبي كلهم من اكبر الناس، استاذ علي دكتور علي والشباب كلهم الموجودين. ويسعدني دعوه الدكتور خالد مبازي والاسم الدكتور محمد قائد المحاضره. الحقيقه انا بقالي يمكن دخلت من اول يمكن 2012 كنت خطفت كده كلينيكال ايمجنج جايد لاينز، سمعت عنها بتاعت الاي ريفير بتاعت انجلترا، بعد كده دخلت على بتاعت الاي سي ار بتاعت امريكا، وابتديت اتبنى الحمد لله موضوع تطبيق الكلينيكال ايمجنج جايد لاينز في الاول في مستشفى المعادي العسكري للقوات المسلحه، وبعد كده ابتدينا في مصر ننشر الفكر ده بتاع كلينيكال ايمجنج جايد لاينز، لان هي احد اهم واول مبادئ الراديشن سيفتي اند كواليتي اللي احنا عملنا ليها جمعيه خاصه تشرف رئاستها. ببساطه بقى يعني بالنسبه للناس الاصغر شويه معانا، الاشعه هي اكس راي، هي كونفنشنال راديولوجي اولا، بعد كده دخلنا حاجه اسمها سي ار دي ار على نفس الجهاز، الالترا ساوند، التوموجرافي، ماجنتيك ريزونانس ايمجنج، نيوكلير ميديسن، هايدرو ايمجنج اللي هي بيت سي تي او بيت ام ار، حاجتين مع بعض، والايمجنج جايدد انترفنشن. بصوره عامه ده سكيما، بس مش سكيما صادقه 100%، يعني هي سكيما عامه ان السوفت تيشو ليجنز وخاصه السوبرفيشال ليجنز افضل بالالترا ساوند. حتى بيستغربوا ناس ان احنا بنستخدم الالترا ساوند ساعات بديل للام ار في الليجنز الاندرلاين للسكين على طول، لان بتبقى مور كاركترايزيشن، بنشوف السكتيشن البسيطه حتى جواها باي مديول جواها. السوفت تيشو ليجنز اندرلاين بون الام ار افضل، لان الالترا ساوند ما بيعديش البون زي ما احنا عارفين. البوني ليجنز مينلي السي تي، البون مارو مش هو البون، البون هو الكورتكس، البون مارو هو اللي جوه الكورتكس، هو البون مارو هو الدايركت ايمجنج موداليتي الوحيده اللي بتشوفه هو الام ار اي. كان زمان
عندنا اجانب
sorry. I think that other our friends from here. Bone marrow is the only imaging modality for the only imaging modality is MRI. Ioscope scanning is another imaging modality, but only detect activities, not the exact site and concentration. X-ray in musculoskeletal system must be two views. Plain X-ray is the first imaging modality. CT scanning, you should mention that you need coronal and sagittal reformatting in your request, as well as the 3D reconstruction. Almost there is not obsolete contraindication for use of contrast media if there is no alternative. If there is no alternative for contrast media injection, it must be done also in females, in pregnancy, in sensitivity must be done to reach patient diagnosis. MRI reach more clinical data, leads the radiologist to choose the protocol, disc or block protocol. Numerous named by sequences by many companies may alter the sequences according to your system or your machine. That's conventional X-ray, the old system, the screen film system. Then the CR and DR, there is a phosphorus plate instead of the film inside. Ultrasound in musculoskeletal system is high resolution for superficial structure. It is interactive, no radiation patient or provider. You could examine both sides in the same setting. It is portable, relatively inexpensive, especially in Egypt. It has educational facilities. The advantage, same advantage. In a musculoskeletal system, tendon or ligament pathology, joint effusion, nerve entrapment, evaluation of soft tissue masses, detection of foreign bodies in superficial soft tissue, planning and guidance for injection. The disadvantages or limitations of ultrasound are the limited field of view. The biggest probe is almost 10 centimeters, so you don't see a global image. Limited penetration. Its operator dependence. I consider it sometimes it is advantage, not disadvantage. Cannot penetrate mature adult bone or hair. CT advantage, relatively quick imaging modality. Require minimal patient cooperation, offer excellent anatomic details. You could measure the Hounsfield unit in CT scanning. The disadvantage, exposure to patient to a relatively large amount of contrast medium, and you see will illustrate some aspect of contrast media clinical guidelines. Conventional CT is we make only one exposure, then the machine stop, then another exposure, then stop at maybe at the first time we experience radiology. Spiral CT scan, there is many names by the companies. GE, it's Philips, it is volumetric, I think. In Siemens, it is spiral. But the name, the exact name or the correct name of spiral CT scan is a continuous data acquisition and table displacement and coordinate speed. Continuous data acquisition. That's the evolution of CT scanning, which make us alter slice thickness retrospectively, reduced examination time, good control between injection and time scanning, multi-phasic studies will be covered, and also you can cover all the body in one exam. Magnetic resonance imaging advantage, no radiation, variable sequences, direct multiple planes, excellent for chest wall and bone marrow imaging, and mediastinal imaging, and geography without contrast injection. Disadvantages may be now it is not long as before, but longer time than CT scanning, less availability and higher cost. That's some of the benefits of MRI study. It shows the bone marrow very clearly. Any alteration of bone marrow segment, whether by edema or confusion, will appear in MRI study. High field MRI study, it will be from 1/2 centimeter, half Tesla to 3 Tesla. The low field MRI is less than 1 Tesla, but maybe it is similar to some extent for lumbar spine and for spine as a whole, but for joints, 1.5 Tesla and 3 Tesla are better than small Tesla MRI in shoulder, wrist, and elbow in many joint spaces. That's also another example. That's for focal tibial plateau fracture in plain X-ray. Almost there is nothing in plain X-ray. CT scanning is a fracture line appear. In MRI, there is contusion and the fracture line appears more clearly. That's shoulder joints. In ultrasound, it is clear in superficial tendons as supraspinatus tendon and biceps tendon. But in MRI, you see the intra-articular portion of joint spaces. That's also the characterization of lesions by MRI studies. Now, we have a long list of contraindications from about 10 or 15 years, but now valves are friendly, pacemakers are friendly, many things are the titanium plates which are replacing the other plates will be better now. The only obsolete contraindications will be electronic stimulator and aneurysm clips. Nuclear medicine is there is a planar nuclear medicine. Then after that, positron emission tomography, it measures the activity or metabolic activity, not the anatomical information. All our imaging modality describe the anatomical information and to a lesser extent functional imaging, but nuclear medicine measures mainly the metabolic activity or activity of the lesion. That's CT alone, that's PET alone, and that's the third image is PET and CT scanning. They include both activity and anatomical details in one study. Hybrid imaging is imaging direct or diagnostic guided imaging, diagnostic or therapeutic. That's some examples. Discogram, astrogram, vertical filtration, supraspinatus barbotage, which is destruction of the calcification of the supraspinatus tendon, vertebroplasty. The clinical imaging guidelines is international project. It consists of justification and optimization. Justification is how to choose the imaging modality and technique. It is a process in which the referring healthcare provider and radiologist make a decision as whether the examination is clinically indicated or whether the benefit outweigh and likely radiation risk. Optimization is another concept. His principle states that the dose should be kept as low as reasonable achievement. If we justify the examination, we shift to the optimization. The main and first, second, third aim of clinical imaging guidelines is the patient imaging practice. So that the patient will proceed in the correct and proper direction of examination, so early diagnosis and early treatment. But the third or fourth aim is the decrease the cost, decrease the radiation dose, decrease the personnel work, but the main item is patient practice. It is found in a booklet, online version or app indication. That's our first exposure in Vienna 2015 to be that Egypt will be considered as one of European Commission countries or it is treated as European Commission country. This I refer, you could enter that site, I refer, and look for the clinical imaging guidelines. There is a small amount of money to enter the digital form, but ACR, American College of Radiology, it is free, but it is somewhat more complicated. That is some examples for the clinical imaging guidelines. In suspected osteoporotic collapse, we begin with the X-ray, then proceed to MRI, and maybe DEXA after that. Some examples for that clinical scenarios. Painful shoulder, we begin by ultrasound, then MR, and sometimes if there is suspicion of bone destruction, you return back to X-ray. Primary bone tumor, first X-ray, but now we make a whole body MR or sometimes CT scanning for some destructive lesions. The static lesion, detecting through screening by isotope scanning. If there is a soft tissue component, MR would be helpful in soft tissue components. Low back ache. In low back ache, usually there is no need for X-ray or imaging except if there is, it is persistent and resistant to treatment. So first, there is no indications for imaging at all. Then X-ray after the MR and maybe nuclear medicine. Don't make imaging for low back pain within the first 6 months unless red flags are present. Red flag includes but are not limited to severe or progressive neurological deficits or when serious underlying conditions such as osteomyelitis are suspected. Begin by plain X-ray, then proceed to CT scanning or MR scanning according to clinical scenario. I'll mention some guidelines for contrast media injection. That is a long list of the portals of contrast media. I collect that intravenous, intraarterial, oral, rectal, intraurethral, intracecal, cervical, through sinus or fistula, percutaneous, ductal opening through the opening of the duct or retrogradely as ERCP, colostomy, and intramuscular. There is somewhat there is a debate and confusion between CT angiography and CT contrast study. The angiogram is to visualize the blood vessel specialist. So the timing of contrast injection is important. They are usually not very quickly after injection so that the vessels are full of contrast before the contrast has a chance to get and fill the organs. We measure the contrast within the blood vessel. So if you want to ask for angiography, don't mention CT contrast study. You should mention CT arteriography or CT venography, not even angiography. CT arteriography or venography for certain organs. The difference also between dynamic MRI and tri-phase study. Dynamic typically means sealing and tri-phase 3 phases, and MRI there are many phases. And there is also some confusion for clinicians about dynamic study, because some clinicians write dynamic study without contrast. They think that dynamic means spiral scanning or a machine, not the type or methods of injection. I proceed to contrast media has two problems: hypersensitivity reaction, which is mild, moderate, or severe. In Egypt, usually we ask patient to make creatinine clearance or urea and creatine in all patients. But the European Society of Urogenital Radiology mentioned only six cases in which we consider creatinine screening: non-renal insufficiency, diabetes mellitus, hypertension, Lasix or nephrotics, toxic drugs, solitary kidney, age, extremity. Just some example. In arthrography, we begin with X-ray examination. Ultrasound and MR for the specialized, what can you see is acute synovitis, and we can use Doppler study to measure activity. Just MRI, articular cartilage, sequence, early erosion, and bone marrow ED. Metastasis, the first imaging modality is isotope scanning, then characterization, CT for polycortex and trabeculae, and for early diagnosis before trabecular destruction, MRI will show the medullary and extramedullary tumors. The causes of inappropriate referral are doing the wrong investigation or wrong imaging techniques. failing to provide appropriate clinical information and questions that imaging investigation should answer. Repeating investigation which has already been done. Investigation is too often, frequent follow-up. Investigation when results are unlikely to affect patient management or not indicated initially. Improper or wrong preliminary diagnosis or interpretation of examination. Guidelines adhere only by expected in up to 90% of clinical scenario, but it is according to personal clinical scenario. That's a plain X-ray. There is some patches in the plain X-ray. We proceed to CT scanning. There is nothing in CT scanning, whether the mediastinal window or the bone marrow window. So the preferable imaging investigation in that case is endoscopic scanning, which shows the bone infiltration, not CT scanning or X-ray scanning. That's the table which is filled in our societies and our hospitals. That's justification, if it's justified or not. It is appropriate or not. If it is appropriate, we measure okay. If it is inappropriate, we show the cause of inappropriateness. Whether it is unnecessary repeats, unlikely to manage, to change management too soon, not best the imaging modality. In Africa, there is 6 countries in Africa which are centers of excellence. Egypt has 4 centers of excellence, and we hope that Alexandria University will be the 5th center of implementation of clinical imaging modalities. After implementation of imaging modalities, clinical imaging guidelines, 30% of all CT examinations were not justified. CT lumbar spine, 77%, are all that are not justified in England and America. In Egypt, our first clinical imaging guide implementation shows that in Kobri Oba Hospital in Cairo, there is 70% of examinations are unjustified. Also in the insurance hospital in Egypt. After we implement the clinical imaging guidelines, it reduced 20% of examination, potential for 44% reduction, reduced imaging cost by 39%, reduced radiation dose by 44%. What is the challenges against implementation of clinical imaging guidelines? Unawareness of physicians and radiologists by clinical imaging guidelines, congestion in clinics, patient pressure to perform the investigation, uneven distribution of machines, fee splitting and self-referral. I will mention about only seconds about fee splitting. Fee splitting is the paying to the referral physician money to send the case or the imaging to center of imaging right or the hospital. That is, in all countries, are illegal and unethical. That's fee splitting, especially paying commission to the referral with the express intention of ensuring that the referring doctor direct referrals to patients to the PE. Self-referral, physician self-referral is a term describing the practice of ordering tests or patient in his same institute or his same center of radiology. All our physicians don't hesitate to discuss the imaging modality and the choice by the radiologist. Radiology is double-edged sword. Mistakes will lead to consumable abuse, radiation exposure, false or delayed diagnosis, thus improper treatments, increased morbidity and mortality. Referring physician should give us patient data, previous examinations, awareness by imaging modalities and ethical concern, choice of good radiologists and departments, communication with radiologists. Radiologists in turn should choose the best imaging modality and technique, communication with patients and referral physician, careful interpretation and proper reporting. Thank you.